Jacqueline, who is chair of the, I'll get this right, chair of the board of Midlands Partnership NHS University Foundation Trust. Phew. So we're delighted to have her here this afternoon, and I'm sure maybe quite a few of you will want to ask questions afterwards. So welcome to Jackie.
Thank you, and thank you. It's great to be here, and thank you for the invite. You've just introduced me. I'm Jackie Small. I'm the new chair at MPUFT. I started at 1st of January this year. I've been with the trust for the last 5 years, and for me, coming to this meeting today, what I want to do is to have a conversation with you. I'll talk briefly, and then we can actually open up to questions and discussion. So for me, what I wanted to share with you today, and as part of getting to know you all as well, is a bit about me in terms of where I'm coming from as a chair at Midlands Partnership Trust. So I suppose some of you may know I've worked in public health and health promotion for many years. But what I wanted to share was my, I suppose, my connection with working with communities, working with people, really just sort of bringing that kind of human approach to me, who I am. And so I started working in health promotion many years ago. I worked in Birmingham, and I just wanted to share part of my story because it's something that's touched me and helped my thinking and my working as I've moved forward. So I worked in Birmingham on a project that was focused on improving life expectancy of men. And they were mainly men living in inner city Birmingham, where it's known that there were high rates of heart disease. And typically, many of these men in deprived communities, aged roughly about 40 to 74, weren't actually touching or connecting with formal clinical services. So in terms of the partnership, I worked with the City Council, but also with voluntary sector organisations, part of a partnership, to actually start working with those communities to understand what some of the challenges were, barriers to accessing healthcare. And again, for me, one of the key learning was about understanding people's challenges in terms of the diverse work that people do, in terms of working long hours, shift work, taxi drivers who couldn't get to formal services. And the data was showing that many of them were actually having quite severe illness, but actually presenting late or actually dying early as a result. So some of the work I did with focus groups was about reaching out, talking to sort of the community, finding out what some of the barriers to health were, finding out some of the solutions that they thought might work, but also working with community leaders and faith leaders to look at some of the solutions, how we could work together to address some of those. And I think for me, one of the powerful learning from that is actually about how you engage with people on their terms to actually find out what their needs are and what their challenges are as well. And so some of the things that we did was around community-based health checks. So working with primary care, inviting people from some of those at-risk communities to have their blood pressure checked, to have their weight done, to have their smoking status, diabetes checks, and so forth. But for me, the feedback is the powerful bit about people actually understanding that they matter, that they're important, and that we're understanding some of the challenges that they face. And so for me, the take home and what I've taken into my career is that the importance of actually listening to people and that co-production and actually engaging and responding to people in the most relevant way, but also collaborating as well. So we use non-clinical settings to deliver this program. I think primary care were quite surprised how many people actually turned up to have their checks because they were outside routine hours. And they were sort of like, do you pay them to come? No, people come because it was actually about meeting their needs and doing things on their terms as well. So for me, that's a real take home for me in those days of the practitioner and how I think as a chair in terms of why communities matter and why people are important and how we actually have that localized approach as well. I wanted to sort of then talk to you about MPUFT, the values of the organisation. And I know we talk about this. And for me as a chair, a new chair, it's really important about that, putting people at the heart of everything we do. And particularly some of the work that Gary's given examples of, some of the success, that's where we're at. We're wanting to put people at the centre. But also for me, it's that delivering better healthcare in partnership with other organisations, with the voluntary community, social enterprise sector, really, really important. And our mission is that about making life better for communities. And I think what's important in this current climate is that for MPFT, we cover 2 integrated care system areas. And so Staffordshire Stoke-on-Trent, but also Shropshire, Telford and Wrekin. And I think for that geographical spread, we want to touch people, not that people who just use our services, that broader community, to actually help people to not use services, to stay well, stay healthy. So certainly the things that Gary's given the illustration of really, really chime with where we want to be. For me as well, and I'm sure all of you are well versed in this, the challenges within the system are great in terms of, we know that we've got an older population. We know that the demand for our services are rising, particularly around urgent and emergency care. But we also know and understand, looking at the data, for many people after the COVID pandemic, for many people, people have presented later in services, sometimes with more advanced, more complex systems. So for me, it's important how we work in partnership to actually look at that and how we can address some of those challenges. Particularly for me, something close to me is around health inequalities and deprivation, and how we reach out and looking at some of the work you do, covering some of the more urban, rural, deprived areas, really, really key in terms of us understanding some of those challenges, particularly as we can see now, people that are on the edge financially are further exacerbated because of the rising inflation, cost of fuel. You know, cost for families is just a massive, massive burden currently and impacting on people. And for us at MPFT, for us, the only viable solution to solve some of this is about how that health and prevention challenge is how we actually work together in a multi-agency approach to kind of address care, health and well-being, and we're actually coordinated in that. So for me, that's the importance of the relationship between yourselves and ourselves. And I think as a system, it's really, really important, because now the system for Staffordshire Stoke-on-Trent has the formation of a partnership approach with, you know, in terms of having the NHS, local authorities and the VCSE alongside each other. For me, that's important as we move forward, that we actually kind of play to our strengths and work with others that have got strengths in the areas where we need to be. Again, for me as well, personally, I wanted to convey today, I recognise, and colleagues at the Trust recognise, the strengths that VCSE have in terms of your unique placement within communities to support people, things around population health. And as I've illustrated my story, it's that connect locally as well. And again, for me, it's really, your role is really essential in planning care and actually helping us to move from that prevention towards prevention and self-care as well. So really, really important. And for me also, that alignment with health and care pathways and the service redesign, which we've seen with some of the mental health transformation, that is key. And again, the work that you've illustrated around social prescribing networks in primary care, really, really important. Again, for me, it's integral, the role that you play in terms of that system transformation and that integration of how we work. So for me, broadly, I feel that deepening the partnership we have with the voluntary sector is important, and it's essential for us in terms of supporting communities and rebuilding as well. Recovering from COVID, for many communities, they're still blighted by the impacts, and particularly around some of the social isolation and some of the challenges that people have had in terms of their health getting worse during that period. So for me, it's really, really important. Again, I wanted to just illustrate, and I know that Gary's highlighted in some of the successes for last year, the work that is being done in partnership. And I just wanted to illustrate, obviously there's the mental health transformation group and a whole series of wraparound support in terms of finance, lifestyle support, housing support, and so in terms of the wider determinants of health. But also, again, for me, that work we're also doing in terms of the community lounges, that social support in the north of the county, where we're actually running some pop-up physical health clinics looking at diabetes checks, blood pressure, foot checks, that kind of thing, and the social support. So for me, those are the key things that I wanted to highlight today. But what I really want to do is to have a conversation, a discussion with you now, to actually get from you some views in terms of what more you feel that we should do to enhance and strengthen partnership and collaborative working with yourselves and MPUFT. So that's my ask today. So thank you.
Thank you, Jackie. Really good invite to others to ask questions. If you want to put up a real hand, Sharon, you've got one, so I'll call you in while others have a little think. You're on mute, Sharon. Just unmute you.
I think it's still on mute.
Oh, we can't unmute you.
Unmute.
There
Yeah.
we go. There we go.
Yes. Hello, Jackie. It's really
Hi,
good to
Sharon.
meet you. Hi.
Hi.
Let's see if I can get back into seeing you now. That's it. Now I'm off mute. That's it. I'm really interested actually because I'm retired now, but a health visitor by trade. So very much interested in health promotion and public health, obviously.
Yeah.
Since I've been retired, our organisation tries to deliver public health messages through the arts,
Yes.
by staging plays and putting messages over visually. So, but I'd love to sort of get up to see you because I think obviously needing updating as well. And I usually use resources to find out to make sure I'm giving the correct information, you know, obviously. And I'd like to sort of meet you to sort of have a chat and talk to you about what we've done in the past and what the next play is all about, because it's around the cost of living and you know, that sort of thing.
Yeah.
And revisiting cancer as well and stuff like that. So it'd be great to sort of meet you and talk to see what you think. And the one thing that just cropped up in my mind was I'd like to be able to not ask for donations for rehearsal space. So I'd try and look at some funding, you know, to see if I could offer free. Most of the time we've offered free and just donations for people to come and rehearse free, if you see what I mean. They don't pay. We do have to charge for the tickets for the play to try and fund ourselves for the next play, but we haven't increased prices since 2017. So if that
Sharon,
would
do you
be-
just want to say for the benefit of others the name of your group?
Yeah, it's the Sharon Rose Author Projects, and we stage plays using the, you know, people in the community, people having a go at amateur dramatics, of course, but using dance groups, choirs, anybody that wants to have a go from age ranges,
Okay.
very
And
wide
where,
age.
and where are you based, Sharon?
In Tamworth, we sort of run on a project basis. So once the play's over, we start again when because they're original plays. So once we're ready, we try and set up again and invite people to come and join us and have a go. It's not such a structured audition process. It's when people show an interest, they're given a go. But it's very it's sort of providing health messages on a visual,
Okay.
Yeah.
a visual basis. So
Thanks,
that's how we
Sharon.
work.
It's dead interesting, isn't it? I think
It
Jackie
is,
had
and
Arts for Health.
I will try and connect you also with, we have an Arts for Health team as well. So
Oh,
I don't know whether that's something that you'd be interested in just talking through to them. So I've got your name and things, and I'll just liaise with
Yes,
Gary around
please.
how I get a message back. Yeah.
That would be
Yeah.
lovely. Thank
Yeah,
you, Jackie.
thank you,
Yeah,
thank
thank
you.
you very much. Thank
I don't
you.
think I knew that, Jackie, to be honest. There was an Arts for Health team, so I think there's probably quite a lot of our
No,
members who'd be
yeah.
dead interested in that. So, Jill, do you want to come in?
Yeah, I was interested in some resonated with me what you were saying at the beginning, Jackie, about connecting with older men, particularly some of the work that that's been trialled in the moorlands around connecting, improving health of farmers.
Okay.
And some of the work linking social prescribers with Everyone Health, who've got the county council contract on public health, and also a voluntary group called the Farming Community Network. Some real issues around farmers not accessing health care. And in fact, one of our local doctors said to me that he rarely sees male farmers, and when they do eventually come into the surgery, their health is often so bad they literally they're at end of life. They're as bad as that because they just don't come anywhere near their doctor. So I think there's a lot more that we could do, certainly around the farming community, but other communities, particularly around older men that really don't come near health services. So I think there'd be some if there was more support for that kind of work, I think that connection with some of those key voluntary groups in the area would work really well.
Okay, thank you. Thank you. That's really interesting. It is a huge challenge. I don't know in terms of public health in the local authority, what work you're doing with them to kind of enhance some of that access. It'd be interesting to find out more about that. So yeah, certainly I think men's health, that's a conversation I can have back at the trust in terms of, although we're very much focused on mental health, it's actually what else is happening that we can connect with. Yeah.
And a lot of that with farmers, it's mental health issues, like
Yeah.
suicide
Okay.
rates as well, of course.
Okay.
I also wonder whether
That's
that
really important. Yeah.
there's some work happening with the more broadly across the system around health inequalities.
Yes.
There's
Yes.
a focus on, and this is nationally as well, what they call
Yeah.
health inclusion groups.
Yes.
I don't
Yes.
think I've ever seen farming communities listed. But I wonder whether they should be. That's not true.
But I think certainly the point you raise around farmers and mental health and suicide prevention, there is we are doing some work internally around our suicide prevention network, but I know annually there is a kind of system-wide mental health suicide prevention conference. So again, in terms of colleagues involved in that, I can raise the issue around mental health and particular groups like farmers and see what's happening to address that. Yeah. Thank you.
Anybody else want to come in? I'm looking to people like Martin around his history of housing and wider determinants around health. I'm sure Elaine's got a view on.
Well,
yes.
I think so. So one, Jackie, one for me will be, I'm going to say, sharing of information, sort of backwards and forwards. There's probably amazing things the voluntary sector and partners could do, but trying to find out who individuals are and what we can help. I think them barriers are starting to crumble. The signs of them.
Okay, brilliant.
But that needs to progress so much more, because you sort of say, I have been in the past in points where we could hand thousands of pounds to somebody who's got COPD, but nobody's going to tell me who's got them, and you can't do that. And I know that.
Okay.
I know that the county, the voluntary sector, MPFT have been working, and the hospital together for literally years. But you do tend to get to a point where you get some very risk averse. It tends to go so far with a positive, and you'll hit somebody who's quite risk averse, and they'll get lost into the ether. I suppose that'll be one thing that I'd be interested to sort of see. It's starting, but you need individuals.
What kind of information, Martin, for example?
Okay, I'm gonna previous. So actually, I'll use a current iteration. Government has said anybody with a respiratory condition, coronary condition, limited mobility can access their energy company obligation funding by referral from their GP. Where are those people? God knows. Are they likely to be disengaged? Yes. Would MPFT kind of hold that information? Sure, they would. Along with the GP, how do you get it? How do you get to those individuals and share that kind of information?
Okay.
I will tell you now, I've got blood on my forehead the amount of times I've hit a brick wall with it.
It is challenging, though, isn't it? Because yeah.
Yeah, there's workarounds, and so that would be one. And I think just the other one, because I do press the rant button now. We've got this you've got this, and I've seen there's some very good, and I will say they seem to be the exceptions to the rule rather than the rule of co-production and putting things together and stuff like that. I think what I tend to see is very good strategic stuff.
Yeah.
Ideally written. I'll see people at the coalface having done that despite their line managers. And I think there's always seems to be a little bit of a problem in the middle when somebody becomes a budget holder. And so just as I'm going to say a challenge for everybody, that moving that strategy down to the budget holders, who will then tend to block the people at the coalface from delivering them strategies. That's not just MPFT, that's across the board. But I just think that's one that I again have come across. There'll be people on the coalface doing brilliant work.
Okay.
Against, I'm going to say it, against what they're being told to do, because there'll be budget holder go, you can't deviate from this for a military, even though it'll work. So I just think that's just another challenge I'll put out there, almost, to sort of go that would be great. I think that would help further co-production and collaboration, I would say, because it's key.
I've made a note because I can raise that in various forums about collaboration and how we co-produce and of the process. So yeah.
There's some interesting
Thank
stuff
you.
in some of the resilience work that we're involved in about talking about creating these sort of unified at-risk registers, essentially. So, at the moment you've got a situation where the water company will have one list, the energy company will have another list, the council in terms of things like preferential bin services will have another list.
Yeah.
And there'll be some people who'll be on all the lists, but there'll be some people who'll be on some of them, but not others. And it's in the main part that people should be on probably all of them. So there's some talk about introducing new ways of almost making that the default and not having to ask consent for all of them all of the time. Almost if you give consent to one, you're giving consent to all. I'm not fully aware of how that crosses over into more of a health vulnerability. If it's more of a general kind of health thing rather than a specific thing to emergencies, it tends to be around, would you be at serious risk if your water was cut off, if your electric was cut off,
Yeah, I
if
get
you
you.
had to
Yeah.
evacuate your home in an emergency. There seems to be quite a focus on that post-COVID around not having those people that were invisible and forgotten about. But I think Martin's point probably pushes a bit wider than that in terms of data sharing.
So it's how it's aligned. So some agencies collect X, some collect Y, some collect, and it's actually, is there a system where they could be aligned so that actually, rather than actually having to vote onto one list? I mean, again, it's probably, I'm not sure within health our influence, but it's certainly a conversation we can raise when people are talking around planning, emergency planning, and all those kinds of things as well, that it's thought through. Yeah.
Yeah, it's really interesting. Elaine, you must surely have a question bubbling around the interaction with, I don't know, acute hospitals, and I mean, certainly coming back to Martin's point about finances, I imagine there's frustration.
I think my big thing that I'd like to share with Jackie is, how do we engage with people so that we don't look at the acute sector to fix people? How do we try and get over that, where people will attend like health talks, for example, but not actually in the acute setting, where we invite them to the local mosque or the local whatever. And I know a lot of people do this, but it's about the joined up thinking of how we do that. And I also realise it will be a trickle down from the people who always want to go to those things because they're interested, to the people who don't go because they can't get there, or they can't communicate because everybody wants you to be on a Teams meeting or a Zoom meeting or whatever, and the face-to-face with a cup of tea and a biscuit. And if I can digress, I went to a building society yesterday and I was met with a mug of coffee as I walked in, simply because they wanted that community spirit, where people would sit down and have a little talk before they did whatever the business that was. And if you were young and dashing out to work, they gave them in a cup that they could take, a recycled cup. So it wasn't just us old fogies that they were trying to work with. And it's about trying to be imaginative, about engaging is my big thing.
Okay.
I'll pause for breath there.
Sorry?
I'll pause for breath there.
I think some really interesting and important points that you raise in terms of people connecting, people actually having the time to do stuff face to face. I know that we're a foundation trust, and we have a council of governors. We have a number of governors, and they, I suppose, many times will go to different health events, different events happening, so that actually it's the opportunistic, bit like the coffee conversations around health and well-being and where things are. So I think that one's something that's really, really difficult, but I guess it's something that we're grappling with as an organisation, where our governors go and what community events we participate in. Yeah.
If I can just add, Jackie, I'm a governor at UHDB.
Okay.
And I think we've got all these governors who really want to do this stuff, and we need to stop wrapping them up with red tape and letting them do it. And I notice we're being recorded, Gary. Thank you.
Well, I have been a governor on UHDB.
I know.
And I'm currently a governor at MPFT as a BCSE appointed governor. And I think there is a bit of a contrast between acute governor and community governor. I feel like with MPFT, I'm not saying this just because Jackie's here, but I feel a bit more like it's you're allowed to kind of get on with it and to some extent ask for forgiveness later
Yes.
if it doesn't go perfectly to plan, whereas it did feel a bit with the acute like you needed to ask permission. There's a slightly different approach to the relationship with governors. So I think it's quite a positive environment and atmosphere I've felt within MPFT. I've certainly found it really interesting understanding how it works, because it's a very big, very complicated organisation.
Absolutely. Yeah. Thank you. Thank you.
Cool. Thank you.
Ian, you must surely have something about social prescribing to say. You're on mute.
Yeah, I have quite a So I'm kind of like being very careful what I say, but it's kind of like the actual gaps within some children and young people social prescribing seems to just fall through the net, even though there's been pilots and joint funding brought in by the voluntary sector and lottery money, etc., that have clearly demonstrated that. And the actual relationship and the communication between MPFT at that kind of level is confusing at best, and it's just, how can we work together at actually including that and actually looking at the confusion between what primary care networks, PCNs, are actually involved in commissioning against what ICBs are commissioning, and then where your organisation sits within that. So that's the kind of like the social prescribing elements, and it's extremely frustrating when we've demonstrated that the voluntary sector can add real value to that. Okay. And then I suppose another kind of question, and this is kind of like slightly different to the question, is every time I go to the meetings, there's lots of like underspends on vacancies with MPFT, and I'm just wondering at what point could the voluntary sector actually help in some of those key areas around staffing and retention, and just to see if that money could actually be kind of not recycled but reutilised by just thinking outside the box.
Okay. That's quite a big question. So when you say what meetings you go to where you get told about underspend and staffing,
well, they vary from the PCNs or lots of kind of statistical data that's coming through, the Children and Families Forum, for instance, around some of the kind of not missing, because I don't think it is about missing targets. I think it's explanations that are given that actually not being able to fill gaps and the capacity in the system.
Okay. I mean, I'm less clear to some of that, but less close to some of that. But what I would say is, in terms of me understanding some of the difference in the primary care network, what you're saying in PCN in terms of their social prescribing, and also what MPUFT do, I can have a conversation with our children's commissioner to see where that element of CYP is picked up. I will have that conversation with her in terms of some of that community element. In terms of staffing, it's not always that simple in terms of just moving funding from one pot to another. There's a more kind of, I suppose, complexity to it. So that's something that I couldn't really, it's not something we could probably address today or pick up, but it's, obviously I can follow it up, but it's not as clear cut in terms of staffing, and then you can just transfer the money somewhere else. So yeah.
But I think the simplistic side from the voluntary sector is that we talk about co-production, and then we still have some bottlenecks around funding that could be cascaded and diverted to the voluntary sector. And it is about those local conversations that we all talk about in all of the kind of incentivifications from the ICB downwards, and being valued members of that service. And it's just like, and how can we move that conversation forward really in a constructive way?
That's really helpful, and certainly when I'm at those meetings, I can raise some of these as questions or just to see where we're at and where things are flowing, because obviously they're really important points you've made in terms of some of the bottlenecks. How do we work together better? How do we kind of strengthen our approach to co-production together? Yeah.
So declaring an interest, but the children and young person service that was piloted was at East Staffordshire. So it's the only one in the country that's been piloted, and it's had great success. And we're literally a week away from not having any funding to continue that service. So it's kind of like a real urgent kind of matter. Okay.
I mean, I absolutely get that. And as you know, the NHS goes through a planning round, and sometimes that timing, that sequencing, there's always that kind of challenge at the end. It's not helpful to you, but it quite often, because of the way funding is managed and run. Yeah.
Okay. Thank you very much.
I will have those conversations. Thank you.
Okay. Thank you.
It's interesting, Elisa, I think is on the call, or at least was, from Bass. She might still be on the call. We've had, yes, she is. We've had some interesting conversations with the ICB in the last few weeks about the disparity between perhaps how some of the voluntary sector are treated as the fallout of those planning rounds. And we completely get it and understand that a lot of this is dictated nationally top down. But the analogy that Lisa will use is if the hospital trust doesn't have the contract signed and sealed, it doesn't put its entire workforce at risk of redundancy and think that it might be closed on the following Monday. It pretty much knows that the hospital's still going to exist. A few weeks later, the voluntary sector feels to be at the other end of that spectrum often, that it's pretty much not sure whether it's going to have to put its team at risk of redundancy and won't have that service. And I guess sometimes MPFT feels a little bit somewhere in the middle in those rounds, because it's probably not guaranteed, is it, that everything that you're currently funded to do is going to carry on in the way that a hospital's always going to be there, whereas MPFT's community services are not always guaranteed and have been subject to cuts and things in the past. So interested in your perspective on that, being somewhere in the middle.
I think being somewhere in the middle, obviously there are key services that we have in place. Some of the detail I wouldn't be able to kind of come through, but certainly from our perspective, as you're aware, in terms of mental health transformation, we're always trying to ensure that we can do things in a much more efficient but effective way. So rather than actually taking things away, it's about how can we do things differently, which is at the heart of how we transform. So our priority is obviously ensuring that we can actually sustain and support service users, patients, their outcomes, their health, their well-being. But actually, sometimes it's about doing things differently and how we do them. So that's the approach we've taken, really. Yeah.
Thank you. Elaine.
Yeah, I just wanted to make a general comment, really. It's obviously excellent to have Jackie here today to be able to raise some of these issues, but I just wonder whether we could explain to everybody on the call, really, how moving forward people can feedback things to, obviously there are certain mechanisms in place. We've got the Healthy Communities Alliance. How, if people after today want to sort of feedback or have comments or suggestions, what is the mechanism for everybody to be able to do that? Is there a preferred way? Is there a kind of say a mechanism in place? And if so, what should people do? How can they feedback?
I mean, that's what Jackie's thinking. I can certainly answer that from our point of view. The Healthy Communities Alliance is the route that we've set up to do it. I think we've got, looking to Sandra and others, we've got pretty good engagement from MPFT teams actually in attending that. And we also get Mark Cardwell, AD Partnerships, is kind of a little bit more the sort of the corporate engagement with it. I think this is a more general comment, not specific to MPFT, but I think it's still the case at the moment that you could plead ignorance of the existence of the VCS Alliance. I don't think we've quite nailed it, have we yet, Lisa, in terms of making sure that everyone everywhere knows about it. And we've had a recent example where the implication of that has been that 2 bids have gone in to an external funding pot from our ICS, an official bid, and then a legitimate, and weren't breaking any rules, but another competing bid has gone in, and ideally that wouldn't happen in the future. So I think there is still something about how we make it systematic, and I think it's a good challenge, Elaine, in that that isn't all on the ICB's shoulders to make sure that happens. We do also need to look to the big trusts to systematically make that the case as well. So I don't know if there is an obvious place, Jackie, where there's certainly an open invitation from me and Lisa to come and speak somewhere to the right people about the VCS Alliance. If you can think of where the best places might be within MPFT to do that.
Okay. Can I take that one with me and actually raise that? So, and I'll come back to you. So it's about yourself, Gary, and Lisa, to come in to talk about the VCSE Alliance. Yeah.
Yeah, that'd be great.
Yeah, I'll take that away.
Hey, Ben.
Thanks, Gary. Hi, Jackie.
Hello.
I'm going to say this in the nicest possible way. I spend a lot of my time looking for people like you. My question really is about healthcare provision, certainly in the case of rural and semi-rural communities. My day job is the parish clerk to Loggerheads Parish Council, and we sit on the Staffordshire-Shropshire border. So in terms of our sort of placing local government, we actually fall under Staffordshire, but because we're so near to Market Drayton, we have a Shropshire postcode, so very often it causes a bit of confusion around who is actually responsible for servicing our residents.
Okay.
We are a population of 5,000 people, give or take, across what is quite a large geographical area by local government standards. We have one GP surgery, which isn't just for servicing our residents, it's also servicing a wider catchment area. Packed to the gills with patients, not enough doctors. In terms of local transport, we've got a bus service that comes through once every 3 hours, if we're lucky, between Newcastle under Lyme and Market Drayton. And it's a predominantly ageing population as well. We've probably got a lot more children and families than we had before due to the amount of house building we've had, but by and large, an older population. So the question really is, how can we as a parish council work with health providers to encourage greater service provision for the benefit of our residents? Because, you know, some of the things that you've mentioned in the course of answering other questions are things like emergency planning. You know, geographically speaking, we are up on a hill, and when it turns to sort of winter time, if we get bad weather, it can be really bad. So if we found ourselves in a situation where we're suddenly snowed in and we can't actually get out, what do we do about anyone on respirators, our diabetics? You know, how do we get medication to the pharmacy? But also on a daily basis is how can we provide services that people desperately need when they don't drive?
Okay. I mean, that one's quite complex because I guess for us, we're MPUFT, we're predominantly a community trust, so it's mental health care, adult learning disabilities, a whole raft of community services. And I think what you're describing, it's quite a multifaceted, because you're describing a challenge for primary care, challenge for sort of staying healthy and well just every day, and some of the emergency planning stuff. So it is really complex. And I guess I was thinking in my head as you were asking it, where I've kind of raised some of these, and I don't know whether you have conversations as a parish with your local district council about some of these challenges and things in terms of, because it sounds like it's a massive issue around access, isn't it? And so I think from my perspective, I'm not sure I can actually address those, but actually I suppose it's sort of the signposting of where do you go and who are you talking to.
Yeah, absolutely. I mean, we do work with our county councillor. I also work quite closely with the Newcastle South Patient Care Network.
Okay.
We're also involved in a health and wellbeing project with Staffordshire Parish Council Association, where they've joint funded an officer to help town and parish councils with health and wellbeing, but it's more of a promotion of what's going on.
Yeah.
Whereas, as I say, our problem is how to actually get things in, or how to get people to the help that's available. And it is a very complex issue.
It is very complex. Yeah. Sorry.
I often find that I would need help myself, given how many times I want to headbutt the wall.
Jackie, is there a wider sort of question for MPFT as a kind of large trust about its relationship with primary care, particularly where there's some places where there's consolidation of primary care? There's been a fairly high profile closure of a surgery in East Staffordshire in recent weeks, and I mean you're not in an executive role, so I know you can't say yes, no to these kind of things. Not that it would be that simple anyway, but I'm just interested in terms of more of the principle and the ethos, whether MPFT does see itself as having a potential role in supporting that local face of the NHS, albeit recognising it's not your direct responsibility and it's not your organisation.
It is a difficult one, and as you say, I'm not an executive officer, so that's a tough one for me to reply to. But what I can do is I can take that away as a question. So, because to me, it's quite an important one in terms of understanding how that relationship we have with primary care, where there are those gaps and challenges. That's what you're saying.
I think there's also a sort of an interesting disparity comparing somewhere like Haywards, which MPFT is an MPFT facility. It's very much there in the community in that part of Stoke-on-Trent, and I think there's a fairly obvious role that MPFT has there as an anchor, as a literal facility in the community, whereas sort of out in the districts, actually more so in the south of the county, because there isn't that same estate. And I know where I live in the southwest, the big institution there is Cannock Hospital. It's run by Royal Wolverhampton Trust, which isn't even based within our integrated care system. So that can often feel very distant from us. And I mean, I'm not kind of saying has MPFT got ambitions to take on more assets. I know that's really a challenge, but I suppose it's whether there's an ethos and a willingness to potentially support to keep local facilities open and thriving, where a more collaborative approach is needed.
Yeah, that one's quite a challenging one for me, and I think it's something and just taking on what Ben has also raised, I think this is one that I will, and I've just kind of made a note of things that I may come back to you on, Gary. So I'll just raise this with a colleague, one of our execs, who I think is more involved in that area, that I can actually just ask for clarity.
I mean, I guess to some extent, would it be fair to say that sometimes your own teams potentially find that challenging as well, when they've perhaps been used to delivering from a local space and that space changes or is closed or there's less room? Now, I know our social prescribing teams have found it frustrating over the years when there isn't, it's this fantastic, wonderful, welcome service in the community. Can they book a space in that GP practice to actually sit down with the patient? No, they can't.
I mean, we have fairly broad coverage, and sometimes we do have people working from different bases, working in different ways and things. So there are workarounds in terms of where some of our teams are based and how they work. So that, again, in terms of the detail, I will have to go back and have a conversation about that for you. I
think there's a question for the ICS around, I'm not sure that kind of joint estate challenge and opportunity has really been grappled with.
Absolutely. It is a sensitive question. Thank you.
Anyone else?
Okay.
No? Okay. I think we'll probably draw it to a close there. Thank you very much for what you've shared with us, and thank you very much for listening attentively and looking to take feedback and actions on things. Really, really welcome. So thank you very much.
Thank you all for listening, and it's great to meet everyone. Thank you.
Thanks everybody. Should we have a virtual wave and
bye.
So thank you very much.
Thank you.
Thanks everybody.
Thank you.